Hi everybody, I'm Stacy. I'm a registered nurse. If you're new here, welcome in. If you're coming back, I'm so glad to have you. Let's talk about the change that comes in your mindset with transitioning from traditional nursing to the hospice side of things. I think that that's a difficult transition for people to make sometimes. Are you a hospice nurse? Did you have a difficult time making that transition in your role? Are you considering hospice? What barriers do you have to the idea of coming to the hospice sides of things? What things intimidate you? Let's talk about it. And if you like what you see here, then I ask that you subscribe, like, comment, and follow for more. I always read your comments. So let's talk about the mindset that comes with being a hospice nurse. When I became a hospice nurse during COVID, at the end of COVID's big rising, I had been a nurse for many years in long-term care. And so long-term care is not like ICU or anything like that. However, when people are in long-term care, we're still focused on health and wellness and making people better and healing things, right? That is a big focus even in long-term care. I know in emergency medicine, you're focused on saving lives. I have never worked in emergency medicine or in the intensive care unit. That's never been something that I thought I would thrive in. But I did work in long-term care for many, many years as a CNA and as a nurse. And the thing about it is that you're looking at those labs, and if you see something abnormal, you want to make it better. If you see something that's not healing, you want to change your technique. If you find an infection, you want to find out what is the infection and how can we fix it. So even in older aged folks, in our elderly population, we are still trying to heal things and make things better as long as they want that. Sometimes there's a palliative approach that comes into play where a person doesn't want the same type of aggressive treatments that they were getting before in a nursing home or long-term care or skilled nursing setting. But generally, palliative care means that you're not doing the same level of aggression, but you're still doing curative treatments. Whereas in hospice, we're not focused on curative treatments. And I think that the mindset that people have when they're baby hospice nurses is they still have that mindset of how can I fix this? And the fact of it is when a body is dying, you can't fix things. And you're not going to be able to, and sometimes by trying to fix things, you're making things worse for the patient. Because when a patient comes onto hospice, maybe 7 times out of 10, they really, really are tired of getting aggressive treatments, going to the doctor, being poked for lab work. They're tired of those things and they don't want to do those things anymore. They want really minimal intervention that is focused on comfort. When we do things in hospice like treating a respiratory infection or treating a urinary tract infection or giving wound care, we are not doing those things with the idea that it will likely be a cure for the patient's disease process. We are doing those things to prevent discomfort in our patients, right? A UTI is not comfortable. You don't want to be having burning and urination, right? You don't want that kind of discomfort at the end of your life. You don't want to be having a respiratory infection. Now, understand sometimes sepsis happens. Sepsis happens at the end of life, and we're not going to be able to treat that in the home at the bedside because those types of infections often require IV antibiotics or IV medication intervention and 24-hour nursing. Home hospice is designed to keep a person in their home and allow their disease process to run naturally. And it's really hard too for families to grasp that concept too. So it's really important as nurses and healthcare workers in hospice and end of life that we're giving that education about the risk versus benefit of those curative treatments. If you continuously give somebody an antibiotic, you can be doing more harm for them than good. Sometimes you're not going to cure an infection. Some infections cannot be cured by mouth. They're not going to be. Some antibiotics just aren't going to get to that bacteria that is growing in the urine or whatever's going on in the lungs. And then the people who are taking them are too compromised to take something stronger because it can actually be harmful to the liver or the kidneys. And our goal isn't to create more damage, right? It's to create comfort. So if a person's having burning and urgency and issues with their urination, we definitely don't want them to be experiencing those symptoms. So we're going to treat it preemptively. We didn't collect a urine specimen. We just said, there's some symptoms here going on that would indicate likely it's a UTI, and we have some basic antibiotics the doctor usually prescribes for those types of infections. There's some lower level antibiotics. Some things are a little bit stronger. I mean, they have a class of antibiotics that they use for certain types of infections. And the least amount of days that you need an antibiotic, the better. The theory used to be to continue the antibiotic. And I don't know exactly what the teaching is these days because it's been a long time since I've been in nursing school. But I know when I worked in long-term care and I was the infection preventionist in the facility, one of the things that they were saying was once the symptoms had resolved for 24 hours, consider stopping the antibiotic. Now, we used to say if you stop your antibiotic too soon, then you build up a tolerance to those antibiotics. But now what we're doing, and this aligns too with hospice, is that we're avoiding using an antibiotic as often. We want to try to do interventions that are not going to mess with the normal flora and the things that are good in the body. Because if you take too many antibiotics, you can take away what's good in the body in addition to what you're taking away that's bad. And then other things can arise, things like C. diff. I don't know if you know what that is, VRE. They're infections that have become resistant to antibiotics because we overuse antibiotics. So we really want to be conscious when we're using an antibiotic not to continuously use an antibiotic. So the idea of a long-term antibiotic kind of defeats the purpose. Some people are going to constantly have bacteria in their urine. They have a chronic UTI, they have chronic bacteria in their urine, and you're not going to be able to get rid of it, especially when they're 90 and they've been getting UTIs for 20 years. Sometimes you're not going to be able to get rid of that infection. And so sometimes as a hospice nurse, as a end-of-life comfort-based person, you have to get that idea out of your mind that you're going to fix somebody. And that can be emotionally taxing. When a person is at the end of their life, we are not going to be able to fix them. Sometimes we do antibiotics as a last-ditch effort. We do. Sometimes we confuse end-of-life symptoms and infection symptoms. And we will try to treat an infection when what's really happening is that the body is shutting down. And so then those antibiotics get ordered, and now you've ordered medication that isn't even going to be utilized. Maybe 1 or 2 doses happen, and then the person's still like tanking. The mindset that I have had to give to myself, this has been an especially difficult one for me, is that when a person is at the end of their life with a respiratory disorder like COPD, we are taught not to use a certain level of oxygen in patients with chronic obstructive pulmonary disease because what happens is their brain is used to functioning on a lower level of oxygen, and if you give them too much oxygen, then it knocks out their drive to breathe. It makes them not want to breathe anymore. Their brain tells them they don't have to breathe anymore, and then they sometimes get too much carbon dioxide buildup, their CO2, and they can't blow it off, and then that's another problem. However, hospice is comfort-based. So if a person is at the end of their life and they want to bump their oxygen up to 5, 6, 7, 8, 9, 10 for comfort, and they are actively dying, we are absolutely going to let them bump that oxygen up because we're not worried about CO2 at this point. But that has been something that has been a challenge for me in my hospice nursing career. And I've had older hospice nurses say to me, "You've got to stop thinking that way." And that's a challenge for me as a nurse because I worked in long-term care, skilled nursing for 20 some odd years. And I wasn't bumping that oxygen up because I had seen and worked at a facility where a patient actually did pass away as a result of their CO2 being too high because people kept turning up the oxygen. Something that you can also do with patients who have COPD for their comfort is encourage them, if they have those BiPAPs and CPAPs, to use them at end of life. And you can use things to help them, their flutter valve devices, their incentive spirometers. Those are still okay to encourage the use of. It isn't going to necessarily help things at the end of life, but sometimes it does control those symptoms temporarily. And so when we're thinking of comfort, we're thinking of what can we do to make a patient comfortable within medical reason. Obviously, the doctor is making those decisions, but as nurses, sometimes we have a hard time processing what the doctor is saying. I think it's become second nature to me to accept the dosing of morphine that we use in end of life. And I've realized that it's really not that significant in comparison to somebody who is taking long acting morphine every 8 hours and short acting medication in between. I have really had to change my mindset over the last 20 years in how I feel about pain management. And I remember the first time a hospice nurse came to the long-term care facility I worked at, and she was very thorough in explaining pain and pain management and the way that pain affects us at the end of our life. Because if a person is in pain, they're not comfortable, they're not going to rest, they're not going to have a comfortable death if you're leaving them writhing in pain. So I've really had to change my mindset over the years, which I've come around to that probably like 15 years ago, maybe 13 years ago. I started accepting the idea that I wasn't doing anything to hasten death by giving a person their pain medication, because that is really something that I had to work around in my brain as a hospice nurse. And I think also wound care. So I did treatments for 7 years early on in my career. So I was really focused on wound care, how to heal wounds, but I've also come to recognize when a wound is not going to heal, when it's become chronic. And also there are wounds that happen at end of life because the skin is an organ. And when your body is failing, your skin will fail too. And so sometimes people will have breakdown on their body, sores that develop. You could be turning them every 30 minutes and they're still going to break down because they just don't have the nutrients, they don't have the blood flow, they don't have the things that is going to call those soldiers in their body to that wound to heal it anymore. And so that has been a really difficult thing for me to wrap my mind around as a nurse, is that I'm not going to heal this wound. Now I've come around to that way of thinking, but when I first started in hospice, I think I wanted to do the aggressive things. Like, hey, let's try this now. That's not to say if we have a person who is up and about and walking and talking in end of life that we shouldn't be making those efforts, because again, it's comfort based. And if a person has a wound that's open on their body, they're not comfortable, right? So we do still want to try to heal those wounds when we're able to, but when we get to a place where a person is no longer eating, they're no longer drinking, they're not taking in protein, they're not taking in minerals and nutrients that would heal those things, and also their circulation is now not great, then we have to change our mindset to, how can I keep this patient comfortable while they have this wound happening? How can I prevent infection, which can make things worse for the patient? And how can I keep this wound covered and clean? It becomes an issue of keeping the wound bed clean and covered and trying to prevent additional problems at end of life, because we want a person to be comfortable. So becoming a hospice nurse, I think, is, everyone always says, I don't know how you do it, but I think that if you see death as a phase of life and you understand how important death is for people that are dying, and you're a nurse, I think that most of us have compassion and can get somebody through a death. It is emotionally taxing on nurses to lose so many people in a year, in a month, in a week. And I remember when I was doing admissions for hospice, so many GIP admissions a day. I remember that became too emotional for me, and I couldn't wrap my mind around that much death. So I think it's been a mindset for me too, going from, when you see somebody who's 90 and they're at end of life, I think your brain is like, okay, this is part of the aging process, this is part of the disease process. But I think that the challenge for me was bringing my mind to thinking about hospice for someone that was maybe my age or younger than me, or was perfectly fine the day before and now they're in the hospital on a machine that's breathing for them. And coming around to that way of thinking, that I was understanding that that person was not really alive anymore. The machines were doing all the work for them and making the numbers. ICU is amazing. They do things. Sometimes people do come back from terrible accidents and brain injuries, and sometimes there is hope for those things. So it's been a challenge to me as a hospice nurse to think of comfort-based things when I'm looking at someone my age with a ventilator and they're telling me that that person who has children at the bedside is not alive anymore, and that I need to let the family know that it's time to let them go. That has been a challenge as a nurse in thinking terms of hospice and not healing. And I think that as hospice nurses, where we do our healing and where we do our strongest amount of care is with our patients, family members, and loved ones. I think that that is where hospice nurses are doing healing. And I think I'm really thankful to be a part of that journey. And I continue to grow and learn every day in this job because I'm still kind of young in hospice. I've been doing it for about 5 years now, and that's not a long time in the terms of hospice care and in my career. But I really I don't think I could ever go back to any other form of nursing, having been a part of such a precious, beautiful journey as the end of life. And so I just thought that I would share my opinions about the ways that we think about nursing in terms of end of life versus healing and aggressive treatment. Because I think it's a big challenge to come from an area where you're helping someone to get better to allowing them to decline and go through the end of their journey's end. I worked for a hospice that called it Journey's End, and I thought that was the most beautiful thing. And I'm thankful that I was able to get into this line of work and be a part of such a beautiful journey. What are some challenges that you've had with end of life? What are some questions that you have? How do you change your brain from thinking of I have to fix this to I need to make this person comfortable? I would love to talk about it in the comments. And if you want to talk more, then I ask that you comment. I always read my comments and I will comment back to you. Maybe not right away, but I do read them and I do comment and I do hear what you're saying. So I thank you for watching and I hope to see you soon. Bye-bye.